Stage for this evening, and now I would like to formally welcome you to the Jane Rimsky Theater. And also I'd like to welcome all of you who are joining us at home via live stream. My name is Amanda Kowalczyk. I'm the Manager of Community Affairs here at Landmark, and we're very glad that you all are here this evening. Thank you so much for joining us for this Conversations from Main Street. Before we get started, I would like to take a moment to thank our sponsor of this series, the Angela and Scott Jagger Foundation, without whom this event would not be possible. So thank you, Angela. As you know, we're gathering tonight to discuss the New York Health Act. We have a fantastic panel of experts here to present you with information and answer your questions as well. This event is co-presented by the Campaign for New York Health and the League of Women Voters. I am now going to pass the mic over to Melanie D'Arrigo, who will introduce our panel and take it from there. Again, thank you very much for joining us this evening.
Good evening, everyone.
Good evening.
My name is Melanie D'Arrigo. I am the Executive Director for the Campaign for New York Health, and it is my absolute pleasure to be here with you this evening for this important discussion. Firstly, I would love to thank the Angela and Scott Jagger Foundation for making this conversation from Main Street possible tonight, and I'd love to thank the Landmark and the League of Women Voters for co-sponsoring tonight's event. With that, I'd like to invite my panelists to the stage, please. So I'm going to start by reading the bios of our esteemed panelists. I have to tell you, we are in for a treat. We brought the big guns this evening, and then we'll talk a little bit about tonight's program. So firstly, I'd love to introduce Maria Alvarez, the Executive Director for Statewide Senior Action Council. Maria has worked with senior citizens and advocacy groups as an organizer, advocate, and Director of Housing and Caregiver Programs for over 30 years. She has designed and implemented educational, social service, and leadership programs for older adults. Under her direction, Statewide's federally funded Senior Medicare Patrol has served to alert and assist millions of New Yorkers to avoid Medicare fraud. And on a personal note, I'd like to say, if you are a senior or have a senior in your life, there is no better organization, in my opinion, than Statewide Senior Action Council to help them navigate the many complexities of the healthcare system. So if you're unaware, I encourage you all to get familiar with her organization. Secondly, I'd love to introduce Judy Esterquest, PhD, who serves as the Issue Specialist for Healthcare for the League of Women Voters in New York State, and has led a national team to update the League of Women Voters United States healthcare position with new New York State language explicitly favoring single-payer healthcare, safe staffing, evidence-based cost-saving methods, and delinking insurance from employment. Professionally, she's spent 3 decades advising corporate executives as multinationals and top-tier consultancies. Following a faculty position in the MBA program of the Harvard Graduate School of Business, she holds her PhD, MA, and BA magna cum laude Phi Beta Kappa from Harvard University. She has worked on 6 continents and traveled to 95 countries for business and pleasure. And lastly, but certainly not least, we have such a gift with us this evening. We have the esteemed pleasure of welcoming former Assemblyman Richard Gottfried, also known as Dick Gottfried. He is now a retired Assembly member and the former Health Committee Chair, who was first elected to the Assembly in 1970 at age 23, while in law school and retired at the end of 2022, serving 52 years. The longest serving member of the legislature in New York State history. He had chaired the New York State Assembly Committee on Health since 1987. He was a Democrat representing a Manhattan district, including Chelsea, Hell's Kitchen, Midtown, and part of the Upper West Side. And what you'll soon find out through our conversation tonight is that he is the father of single payer in New York. He is the original author of the New York Health Act, which we will talk about extensively this evening. So please join me in giving my panelists a warm welcome. So I just want to do a little bit of housekeeping before we get started. Tonight, we're going to talk a little bit about the complexities and the federal changes in the healthcare landscape. I'm sure you've noticed, if you've been paying attention to the news over the last week or so, there's been quite a lot going on. So we want to be able to address that this evening. And of course, we're going to delve into the New York Health Act. I will be doing a Q&A with my panelists for the beginning portion of tonight's event, and then we'll open it up to the audience for some audience Q&A. Before we get to our questions, I just want to level set. I'm going to actually ask a question. How many folks in the audience have heard about the New York Health Act? How many folks would say they're experts in the New York Health Act? So very few. So we've got a lot of new learners here. Welcome. I'm thrilled that you're here to learn with us. So why don't we dive right in? I'm going to ask you, Amanda, to go to the next slide, please. Great. So what is the New York Health Act? The New York Health Act is an active bill in the New York State Legislature that would bring single-payer universal health care to every New York State resident and full-time worker in New York State. It would be the most comprehensive healthcare coverage in the entire country. Next slide, please. So you may be thinking, comprehensive, that sounds pretty good. What is that like? So the New York Health Act would include medical benefits as we think of them today, your primary care, your specialty care, reproductive care, etc. It would include all of that. It would also include prescription drugs, dental, vision, hearing, and long-term care services. It's really quite an extraordinary bill. Next slide, please. Great, thank you. And so with the New York Health Act, you might be thinking, well, comprehensive, that sounds pretty good, and it does. It would also include no premiums, no co-pays, no deductibles. So instead of paying a middleman to decide what care we get, we'll work directly with our doctors, we'll pay a small progressive tax and get universal health care. Everybody in and nobody out. You can go to the next slide. Thank you. So with that, I hope we've got a basic understanding of the bill. Throughout tonight's conversation, we'll go into the nuances a little bit more, and hopefully by evening's end, you'll have a pretty substantive idea of the incredible benefits of this bill. So my first question is to Dick Gottfried. So Dick, you first introduced this bill in 1991. What made you decide to write this bill?
Are we on?
Yes.
Yes. I remember the moment vividly. In around April of '91, 3 people from the New York State Nurses Association, Statewide Senior Action Council, and Citizen Action came to my office in Albany and sat me down. And you may remember at that time, there was beginning to be a lot of discussion about trying to achieve universal health coverage in America, in New York, what have you. And, you know, I had heard a little about this notion of single-payer, universal public health coverage. I was kind of skeptical because the main kind of public health coverage I was familiar with, namely the Medicaid program, you know, is not universally regarded as the greatest thing since night baseball. And they sat me down and they said, Dick, we have to explain this single payer thing to you because this is what you need to support. And there were 2 or 3 basic points that they mentioned. Number 1, that having everyone in the plan, rich, poor, everyone in between, having all New Yorkers in the same boat was really the only way to guarantee that it would be a top-notch program. That if the governor and all the members of the legislature and their families and friends and their family doctor were all part of the plan, they would make sure that they were taken care of as well as possible, and 20 million other New Yorkers would get to be part of the same plan. And that unless you have all in the same boat, you really can't guarantee that prices will be fairly set, that doctors and hospitals will be fairly paid, that people will be well taken care of. But if you do have everyone in the same boat, it works. And the second thing was, what is crucial to making it affordable is getting insurance companies out of the picture, so that the billions and billions that we spend every year on insurance company bureaucracy and marketing and profit goes out the window. We're no longer paying for that. The enormous administrative costs that doctors and hospitals spend, mainly to fight with insurance companies, we won't have to pay them for that cost anymore. That cost of healthcare will drastically go down. And finally, we will, by representing 20 million customers, we will have the bargaining clout to bring down prescription drug prices, which today nobody can really do. And so, having all in the same boat and getting insurance companies out of the picture, put all that together with progressively graduated tax funding, you can dramatically expand the benefits, cover the uninsured, get rid of out-of-pocket costs, cover long-term care, which almost nobody today has insurance that covers long-term home care or nursing home care. You can do all of that by going to a single-payer route. And it was like a light bulb going off in my head. It made perfect sense, and it has guided my thinking ever since.
Thank you so much, Dick. You know, listening to the origin story of this bill makes me very thankful for Citizen Action Statewide, the New York State Nurses Association, for bringing this to you. But it strikes me that that story, we see that happen over and over and over. And I hope that will be similar to your experience here tonight. When folks come and listen to the facts and really understand what we could have, what we could do, how we could center healthcare. Really, I think is a common theme. So we appreciate you and thank you so much for the work that you have done and for being a perennial advocate for us. I am going to ask you another question while I've got you, if that's all right. You know, the New York Health Act would lead the country in terms of prioritizing actual healthcare. We just heard Dick talk about kind of removing that insurance industry profit. But this bill, I mean, really would just put us on equal footing with every other industrialized country in the world. And I wonder if you can talk to us about the data trends of countries that have universal healthcare and how they differ from our healthcare trends in America.
Well, every other wealthy industrial democracy on earth has a universal healthcare system. They don't all have a system like what the New York Health Act would be. Our neighbor to the north, Canada, has a system most like New York Health. The other country I know that has a system almost identical to what we're describing with New York Health is Taiwan, which I'm a little familiar with because my daughter-in-law is from Taiwan. Interestingly, they adopted it. They have two major political parties in Taiwan, a center-right party and a center-left party. Interestingly, they adopted their universal health coverage plan at a point where the center-right party was in control, which I find interesting. Anyway, you know, the United Kingdom has true socialized medicine. Doctors, hospitals, they are all government employees. The New York Health Act is not that. There are some European countries where a universal health benefit that is publicly financed is administered through a series of private companies that all deliver the same product. I've never quite understood why they think it makes sense to have several different companies all delivering the same product. It's not like they can compete for whose, gallbladder surgery is better. But there are a great many countries that do something very similar to the New York Health Act. If you look, and an organization called the Commonwealth Fund every few years puts out statistics on all the wealthy industrial countries on earth. And all of them spend dramatically less on healthcare than who? The United States. We spend radically more than they do. We get radically less coverage than they do. And our life expectancy in America is dramatically less than in all of those other countries. So thanks to their universal health coverage systems, they actually spend less, they fund it more fairly, they have better health care, and live longer than we do.
Thank you so much. My next question is for you, Maria. With every new presidential administration, we can expect changes. What healthcare policy changes are you seeing with the new presidential administration, and how does it affect New Yorkers?
Do you want to grab the mic?
Oh, well, thank you for the question, and it's nice to be here today. So some of the healthcare policies that are changing we're seeing will make it a lot more difficult for consumers to navigate the system. And it's something that we've been seeing all along, but now they're going to become even more radically difficult. Right now, there's a proposal there's a proposal to block grant Medicaid, meaning that right now Medicaid is distributed throughout the country based on formula, based on what the need is for each community. If they block grant Medicaid, what they do is they make it so that it's just one large block of money, and that is what the state has to deal with, regardless of what the need is. So we've seen that Medicaid is a very important, piece of policy and programs, right? Whenever there are disasters, for example, in California right now, we see, right, that those people are going to need Medicaid, right? Whenever there's a storm, in Florida, things like that, all of these systems step in to be able to help people in need. But if they block grant and they say this is all you have, then there's going to be a problem, because then there will be people who are going to will be in need. Medicaid makes up at least 52% of the budget of any state in the union. It might be more in some states, it might be less. In New York State, it's the largest budget line of the budget. So if they cap it at a certain rate, then that will push other, it'll basically mean that other lines to be able to provide services have to be juggled to make sure that we have schools, that we have roads, that we have other things, right? And which means that those expenses might be pushed onto the taxpayer. So that is one of the largest things that we're advocating right now, and we're looking at, because we want to make sure not only that Medicaid is not block granted, right, that it's done based on need, but also that, for example, Medicare, which is for those people 65 and over largely, is not privatized, which is another issue that we've been seeing. And I think that the New York Health Act, if implemented, would be much more beneficial to the state and to New Yorkers, because it would, number one, reduce costs to the state and to the taxpayers, and more people would have access to more resources.
Thank you. I just want to open it up to see if Dick or Judy want to add to that. It's okay if you don't. I know, I'm putting you on the spot. No, it's okay. It's totally fine. We've got tons of questions. I think Maria did a great job. I'm just going to add to it a little bit as well, if that's okay. So I do want to go back to this notion of block grants, because that was something that I was not familiar with. And essentially, when Maria says the state will be given a block of money, right, a definitive amount of money that they have to work with to fund healthcare for those on Medicaid, who are generally our most marginalized people, right? So we're talking about people with disabilities, seniors, low-income folks, children. Thanks, see, you had something to say. These block grants are, and Maria, you can correct me if I'm wrong, but it's never generous. Right? It tends to be, it tends to really hurt in the sense that it's not enough, right? So we know that will hurt people. And when Maria says that if these block grants are instituted, the money's got to come from somewhere, right? So like she said, that might mean less money for our schools. That might mean less environmental funding, right? And so it
might be more property taxes for
it might be more property taxes. So it's really important, and there are lots of federal changes, and I hope we'll talk about them more today. I mean, Medicare, Medicaid, those are the biggies. We don't yet know. We are, I think all of us are actively paying attention to the new executive orders that are coming out to try to determine, what the implications may be for individuals in our orbit. Just before we took this stage tonight, I found out there's a new executive order banning gender-affirming care. Earlier this week, there was an order trying to strip federal money for organizations like Planned Parenthood to support reproductive care. So I think there's a lot for us to pay attention to, and one of the reasons I'm so excited about this bill is because this bill would essentially act as a barrier to all of these attacks. And if we could implement and pass this bill, it would really not only expand our healthcare, but it would protect our healthcare from any impending attacks.
So I just want to make a comment on, so yes, I agree. It's not like you can build a fort around New York, but if you set New York systems in certain ways, it is protected. I just want to add one thing to Dick's comment about the U.S. paying on average, Americans paying on average twice as much as the average OECD country citizen pays. So Americans pay about $12,000–14,000 a piece for their health care, everything in. And in the peer countries, the average cost is about $7,000. And we say, oh, but their taxes are so awful. Well, those countries that have universal health care, they pay less in taxes than Americans do for health care. We already pay over half of that $14,000 in taxes, and many of those taxes, many of the dollars of those taxes, go to insurance companies for administration, for profit, and for fraud. It is just, and we hear about the healthcare companies, the health insurance companies and others like United Health. They are the most profitable companies on the Dow Jones, on the New York Stock Exchange. There's a reason they're the most profitable. It's because they're taking profits. So we're already paying in taxes what other countries are getting: longer lives, better health. They're not skipping on medications. They're not skipping doctor visits. They're getting their chronological. They're getting their diseases covered. So yes, Nick, looking outside the borders is a good thing for everybody.
So Judy, that's a really good segue to my next question, which is actually to you. So many New Yorkers are struggling and sacrificing to make ends meet. How do you think this bill will help New Yorkers with affordability?
So that is a large question. Well, first, I would say there's kind of 4 ways I pick it up. The first one is that New York State, on every dollar it pays for health care, will pay less for health care and get more with New York Health. And what I mean by that is, about 4 or 5 years ago, the Rand Corporation did something that had never been done before. they did a $250,000, or was it $400,000 study, $400,000 study, to figure out how much New York spends on healthcare. And I did not realize that was a big deal until various people were telling me, Judy, that's a big deal. They actually figured it out. And they figured out where the dollars come from, and they figured out where the dollars go. And under New York Health, New York, meaning New Yorkers and the state and everybody, would spend less on healthcare and get all the goodies that Melanie's talking about, including long-term care and dentistry and hearing aids and, all the things that we don't think of as getting covered. So that's one thing. The second way of picking it up is at the individual resident level. And right now, about half of insured New Yorkers, these are not the deadbeat uninsured ones, not that I think they're deadbeats, but these are the insured New Yorkers, about half of them are underinsured. Underinsured being defined as they skip prescriptions or cut pills in half in order to not pay the co-pays, or they share prescriptions with a family member, or they don't see a doctor when they should because of the cost sharing, co-pays or whatever, or they don't test their blood sugar as often as they should because the supplies are so expensive. And the thing that I find just amazing is they do not get free preventive services. The Affordable Care Act, Obamacare, has a number of preventive services that are free. Mammograms, various bone density, every so often, but you're not charged for them. And if you're underinsured, you are so nervous about seeing a doctor, you don't even do the free stuff that keeps you away from the emergency room. So that's number two. That's for residents, it's important. Number three is for when you have better coverage, you live longer, have better health, and you are more productive just in life. And this is because when you actually see doctors, and you have a family doctor, which you could under New York Health, because with employment covered health care, your doctor changes every so often. When you have employment that's self-insured, the employer recently, there's an acceleration of changing your networks and your doctors. But if you actually have a family doctor who's steady, you get preventive discussions. You get advice. You can get this doctor to actually know you. And the doctor won't spend all their time typing in the things with the computer in your 20 minutes, because those things, by the way, are billing codes. They're not actually your medical history. They're billing codes. And the doctor can have eye contact with you and possibly, diagnose you and treat you better. That is, for me, affordability, because I actually have what any normal person would call health care. And the very last thing is around towns and cities, which I know I'm going to get a question about, so I might as well just,
Why don't we hold on that one?
No, I'm just going to, to the high level.
Okay.
Our towns and cities will have their budgets decrease, because when healthcare is cheaper for all of us, it's also cheaper for the employers that are paying for healthcare, like our towns and cities, and libraries and schools and so forth.
Yeah, I think affordability is really a central concept here. I can't think of anything that New York could do that would do more to promote affordability of life in New York for almost every single New Yorker than adopting the New York Health Act. Now, it's not just me making this up. There have been detailed economic analysis done on federal single-payer proposals, state single-payer proposals, including the New York Health Act, the RAND Corporation, as Judy mentioned, spent,
Perry,
excuse me?
UMass Perry.
Yeah. Rand Corporation spent $400,000 in grant money doing an analysis of the New York Health Act. What they found, and here are the specific numbers for New York. The New York Health Act would save New York about $60 billion a year in about $25 billion or so in insurance corporation profit, bureaucracy, marketing, over $20 billion a year in healthcare provider administrative costs, and close to $20 billion a year by bringing down drug prices. Now, that's savings of about $60 billion a year that New Yorkers would no longer be spending, not as consumers, employers, taxpayers, what have you. Now, on the other hand, the New York Health Act will spend more money. The New York Health Act will pick up what we now pay in deductibles and co-pays and out-of-network charges. No out-of-network charges under the New York Health Act because there would be no restricted provider network. Everyone knows that Medicare and Medicaid do not pay doctors and hospitals to reflect the full cost of care. Under the New York Health Act, there is bill language that guarantees that doctors and hospitals would be fully paid, not underpaid like under Medicare and Medicaid. And as I mentioned, long-term care, home care, nursing home care will be covered. You know, my mother in her final years needed round-the-clock home care. She did not have home care insurance. I bet if I asked, I don't know how many hands would be raised. Anybody in the audience have long-term care insurance? Ah, okay, well, very impressive. I could have raised my hand. Because years ago I said to myself, you know, I'm the health committee chair, I really ought to have long-term care insurance. It costs me and my wife an arm and a leg. Someday, maybe it'll turn out to be worthwhile, I don't know. But the New York Health Act would now pay for that. And so, you know, in my mother's case, it darn near wiped out a lifetime of savings. That would not happen under the New York Health Act. So the net savings under the New York Health Act would be almost $20 billion a year net savings, not increased costs, net savings. Give you an example. The governor is proposing I think she's calling it a middle-class tax cut. That would save New Yorkers about $3 billion a year. When people heard $3 billion a year, a lot of people thought, gee, that's a lot of money, that's pretty good. Well, the New York Health Act would save New Yorkers more than 6 times. Do I have my arithmetic right? Almost 7 times that $3 billion. Money back in the pockets of New York consumers, in the pockets of doctors and hospitals, in the pockets of employers. So you talk about affordability, there's really nothing we could do to promote affordability in New York in the same ballpark as enacting the New York Health Act.
So I just want to emphasize that health policy economists who study this stuff for a living, a few dozen of such studies have all found single payer to be less expensive, covering everything. But the Rand Corporation actually came up with numbers that Dick's talking about. So this is not smoke.
And we'll show a chart a little bit later in the program that really breaks it out and hammers it home, but I think Maria wants to make a point from the senior perspective, if you want to pass the mic.
So a couple of things. One is about affordability. So I always say one thing is to turn 65 and to afford to qualify for Medicare. The other is to be able to afford it. So it turns out that seniors 65 and over spend about 37% of their income in out-of-pocket costs for healthcare. That includes drugs, co-payments, doctor's visits that are not covered, hospitals. And, little by little, through some advocacy, we've been, been trying to whittle away at those costs, but it's still very expensive. Now, the other thing, though, that's happening is because we have these Medicare Advantage plans. And the plans, number one, Medicare pays them at a higher rate than other plans. We advocate always, aside from single payer, would be original Medicare because it only has a 2% overhead versus about 30%. Yeah, for 30 different plans. So New York has a lot of choices, and so they're paying 30% of overhead before getting to $1 of your care, right? So it's 30 executive pays, 30 ad campaigns, 30 everything except your health care. Whereas Medicare only has a 2% overhead because it's just basically something that's there that we pay into and we get. Now, these Medicare Advantage plans though get a higher reimbursement from Medicare, which means that the plans then are more incentivized to market them to the people, right? To the consumer. It's been proved that the reimbursements have been more. The costs are higher. The government pays more than they should, and the results are even worse than other alternatives of Medicare, than if you were on a Medicare Advantage plan. It's gotten to the point though, and it's not here just yet on Long Island, but in other parts of the state and in the country, that many of these plans cannot come to agreement with the healthcare systems in localities. So for example, if you're in a place like the Capital District, Albany, Saratoga, around those areas, there's only like 2 healthcare systems that people can really, because now it's not just an individual doctor, right? You have a healthcare system. And so there's really 2 main ones. And if the HMOs cannot come to agreement with those healthcare systems and they pull out, then all of the people in that area don't have coverage unless they change their plan, right? Their coverage. So that right there is a big problem, right? Because if we had, the alternative would be if we had New York State single payer, there is no plan to go to, right? Because everybody would be under the same payment system. You don't have to choose a plan. You're not paying that extra 30%.
You choose a hospital.
Yeah.
I would say you choose a doctor, you choose a hospital. You don't have to choose insurance.
Just to interject quickly, for those who may not know, Medicare Advantage is essentially privatized Medicare.
Hold on a second. So now we at Statewide we have government contracts where what we do is we help people navigate the system, right? The insurance system. We're not brokers. We don't charge. We just give information to make sure that people can make the best decision. This year, we have found that number one, there's not one Medicare Part D plan for the drugs that will cover all of your prescription drugs. So it's more expensive, it's more confusing, because they don't make it easy for you to make these choices either, right? And it doesn't matter what level of education you have. So, I always say if it were me and I was graduating and I was retiring and I wasn't in this line of business, I wouldn't know what to do with my health insurance. But, so they've made a system that is so complicated and more expensive and not conducive for people to actually access their health care. And that increases the healthcare barriers, right? That we all, no matter where we are, no matter who we are, no matter what our economic station in life is. And so then we're gonna be sicker, right? Because when we're not accessing healthcare, like you were just saying, Judy, we're gonna end up in a, when we end up finally getting to healthcare, it's gonna be in catastrophic, situations, which will then become even more expensive. So that right there is a reason why we advocated at the beginning with Dick for the single payer option.
Thank you all very much.
And I just add one other, Medicare Disadvantage also cherry picks and lemon drops. What that means is they try to find the healthiest seniors. And why is that? Because they don't cost much. What's the healthiest person that a health insurance can sign up? Somebody who doesn't need health care, right? So they look for the healthiest seniors, and they go out of their way to drop any senior that gets expensive. So how do they do that? Well, I had a friend who lived in the Bronx, and her friend said, oh, I've got Medicare Advantage, I don't pay anything, I'm great. Then she got a cancer diagnosis, and she could find 2 oncologists who were in network, and none of the hospitals gave those oncologists privileges. So then she looked for hospitals that could treat her kind of health care, and they were out of network. So she moved to original Medicare, because with original Medicare, you can go to any doctor or hospital you want. That's cherry picking and lemon dropping. So as soon as you get expensive, Medicare Advantage doesn't work for you, and you switch.
Right, and so to bring it back, you can start to hear through these nuanced conversations and what our panelists are sharing. It's pretty complex, right? The healthcare system, or the sick care system as I like to call it, is pretty complex. But I do want to just, so I like to make a fine point on things, and we heard about the affordability issue from various different perspectives and looking at different populations. But just to fine point it, what we heard was that the New York Health Act not only would give us medical coverage, prescription drugs, dental, vision, hearing, long-term care, but it would put money back in our pockets, right, on the individual level. That's very, very important. So I want to thank you all for sharing those perspectives. Maria, you sort of preemptively answered part of my next question, so you can tell me if you want me to move along, but I suspect you probably have more to share. She's such a wealth of knowledge. I was wondering if you could just talk to us kind of briefly, because I know we're sort of coming up on time, about the challenges senior citizens face, not only when accessing healthcare, but in navigating and managing ongoing conditions.
Yeah, so, I think I pretty much said most of it, but basically, the other thing is the advocacy point, if it's such a very complex system, you don't know what you don't know, right? And so many times we have people calling us, not knowing why they've been denied, services, why they've, and many times it just seems unreasonable, and those are, and what we find basically in a nutshell is that healthcare is dictating, the insurance company is dictating the healthcare, and that is not what healthcare should be.
That's right. Thank you for making that point. My next question is for Dick. So in Port Washington, where we are here, we have a lot of small business owners, and I think that's true around the state. So I was wondering if you could talk to us about how small businesses would benefit from the New York Health Act.
Yeah, health coverage is one of those areas where our economy really screws small employers. Any of you who are a small employer, this is no surprise. The larger the company, the better deal they get from the big insurance company. A lot of small employers feel they can't provide coverage for their workers, which means you hire somebody new, you train them, they get to be really good, and they turn around and get a job with a bigger employer that provides health coverage, and you're back at square one. And the owner of the company, if they want health coverage, they are in the individual market, which is the worst place, the most expensive place to be buying health coverage. Under the New York Health Act, most small business employees are towards the middle and lower end of the pay scale. And under the New York Health Act, the basic funding would be through a progressively graduated tax based on ability to pay. And so low and moderate middle income workers and their employers would be paying actually a lot less than they are now spending in health care and health coverage. That's one of the basic findings of the RAND study and others, that about 95% of New Yorkers will be spending less under the New York Health Act than they now spend on health care and health coverage. And so for small employers, the New York Health Act would be an enormous step ahead towards stability and profitability for their company.
Yeah, and I wanted to just back up what you're saying, because at Statewide, we pay 100% of our employees, health insurance and family health insurance. So I know exactly how much it costs to insure a family or a person. And I have to say, from year to year, it can go up to 16% from one year to the next in how much health insurance paid. And so that's 16% that I have to cut from other areas in my services, because to me the commitment is, especially doing this type of work, to make sure that our employees don't have to worry about their health care, and that they can come to work and their families as well. So it would be so much more, we could do so much more if we didn't have the burden of 16% year over year.
And that's a not so fun fact about the insurance industry. There's something called medical trend. Every year, health insurance goes up. Every single year. Usually, at a minimum, it's 8 or 9%, but you can see it can go up as high as, you said, 16%.
So there is a very interesting graph which shows Canadian cost of healthcare premiums and American cost of healthcare. And it shows they track pretty much the same until about the 1960s, 70s, at which point the U.S. passes the private HMO, which allows Blue Cross and Blue Shields to privatize, and a few others. And you start seeing a gap. And over the next 70 years, that gap has grown to about $2,000 to $3,000 in estimated cost between the two countries. Because when you have universal health care and a single payer sort of funding, the rate of cost is about 2/3 the rate of what we have. And when you look at how it works for other sorts of insurance, private insurance is by far the fastest growth. And when you're talking about clamping down on how much healthcare costs, one way to do it is to take out the profit, because profit seeks more profit.
Now, how wonderful for small companies, right, to be able to not only give the gift of health insurance to their employees, because many small companies cannot. Many brokers just will not insure them, right? So being able to do that is, I think, a huge benefit to employees, but also a distinguisher in the marketplace, so that to keep them in the business, to help them grow these small companies rather than lose them to larger corporations. So thank you for that point. Amanda, I'm not sure where you are. I'm going to ask Judy a question, and I did put together that chart. I think if we can put that up on the screen, it might Yes, perfect. And so folks, I'm going to ask you do not look at the man behind the curtain. For right now, just don't look at the chart just yet until you hear the question. This is sometimes this chart can look a little scary, but I promise we'll make it seem easy in a moment. So Judy, as we're talking here tonight, the New York Health Act, we know it would cover every New York State resident. It would also cover every full-time worker in the state, which is a really exciting provision. That's 20 million New Yorkers, right, who will be able to access real health care. Not insurance, but real health care. So can our current healthcare system support all these new patients, and is it really affordable?
So I hear that in two ways. First of all, we're talking about every resident, whether or not you're working. So healthcare doesn't belong to the head of the family because the head of the family is working. Healthcare belongs to the 4-year-old and the 14-year-old and the not working spouse or the disabled person in the household. It goes to the person, not through the job or through the household.
So it's decoupled from employer-based insurance, which most of us are used to. Everyone in the state is entitled to health care.
And it is decoupled from some sort of income eligibility. So with the ACA, many of you realize that there's a cliff, and if you make too much money, you're not eligible for that anymore. So there's no cliffs. You're a New Yorker, you have health care. It's like it's a human right almost. What a thought. Okay,
Right.
so
Yeah, let me just set you up for this, okay? Because we some of us, we get very excited when we talk about this, and it's hard to stay, definitively in the questions sometimes. We heard a lot over the last couple of questions about the savings and the affordability, and you might be sitting there thinking, yeah, that sounds great, but maybe that sounds too good to be true. How could that be? How can we get all this amazing health care and it costs less money? How can that be? So Judy, I wonder if you can...
So I'm happy to do this chart. I thought the other one was will there be enough physicians to handle it?
Well, let's do
So
this
let's do
one
this. So starting on the left-hand side, think about how many, if you've ever been denied and you have to call an insurance company, how many people you've talked to. Insurance companies,
Has that ever happened to anybody here? Every single one.
they hire an army of people who answer the phone and use scripts to tell you no. And there is very high turnover in this business because, gotta tell you, it's one of the dreadful jobs in the world. You think about the Walmart greeter or the McDonald's French fry person, I gotta believe that these insurance frontline people is a terrible job. By getting rid of them, that's all we're talking about. These armies of people who just, their job is to say no, and if it's, or to say, well, you can write a letter, you can use this form. So that's about $20 billion in savings. Then there's hospital and provider insurance. When you go to a doctor's office, have you ever noticed how many billing people there are in the office? It is typically at least as many as doctors to twice as many. You know, doctors won't, one example that's often given is that Toronto General Hospital, which has about the same number of beds and about the same number of patients year on year as Mass General Hospital or Duke University Hospital. Toronto has 4 billing people, and 2 of them are to take care of Americans. And Mass General and others have 400. We are paying for those 400 as part of our health care. We will not need that many. Because all the questions about coverage and billing and whether you're in or out and your zip code's right and you changed your job, all that stuff, like the fire engine thing, that goes away. So right there, that's another 16 billion. Then, because it is a single system, you can negotiate drugs, like the VA does. The VA gets almost a 50% cut on the price of drugs. And in case you feel or worrying that the pharmaceutical companies aren't making enough money, just in case you're worried, a congressional, the US House of Representatives Ways and Means Committee did a study 4 or 5 years ago, looking at the price of drugs, and the US pays 7 to 10 times as much for the same drugs of the most common drugs. And we mean the same drugs. They are built in the same factory. You know those, when you get pills and they've got 4 languages on them?
Yes.
Those pills. The US pays more for them. Yeah, we're not subsidizing the rest of the world. We're just making pharmaceutical companies very wealthy. They can afford, they bargain with the VA, which has 9 million people to negotiate for. New York has 20 million. Do you think we could probably get close to 50%? Probably. Okay, that's the savings. And as Dick pointed out, it's a lot. Now, let's talk about costs. Covering everybody, so there's nobody who's uninsured or underinsured in New York, and there are no co-pays, and there are no premiums, and there's no cost sharing, and there's no co-insurance, and all the other things that happen, cost share fees, you know, at your local family doctor. That will cost about $17 billion. Now the question is, why would it only cost $17 billion? Well, because even the uninsured in New York are insured. They're already paying for them. So the undocumented refugee goes to the hospital with something, emergency room, very expensive. We pay that very expensive fee. Your lawn care guy, who may or may not be documented, but, you know, whatever, has an injury, goes to the hospital, gets charity care, New York pays for that. So we're already paying a whole bunch for uninsured and underinsured. So that's why it's not as much as you would expect. Improved provider fees. So right now, Medicaid reimburses a doctor for a certain service pretty low. Medicare does considerably more. And private insurance sometimes does even more, unless we're in a non-competitive area, say upstate rural, and then private will also pay very little. But the New York Health Act aims to increase frontline doctors, those are your family doctors, your pediatricians, your therapists, your geriatric doctors, reimburse those frontline doctors at or above what the current private insurance pays. So they all get it. Right now, a doctor's income kind of depends on the income of their patients. Under this scenario, whether you're treating poor people or rich people, you get the same reimbursement. Do you really think that somebody who is wealthy, who is worth $20 million actually gets better health care from a doctor when they walk in and say, I have a fever? I doubt it. Doctors try to do medical standard of care. So that's improved provider fees. It actually doesn't cost that much. Long-term care will cost about $18 billion. That's pricey. When Dick added that to the bill, it made it the best coverage of any insurance anywhere, because other insurance doesn't have that. Drove up the price, but guess what? You're still saving $11 billion, including with long-term care. And by the way, long-term care is what drives an awful lot of families into bankruptcy. It is a real issue. And until Congress got it together and said, if you have a couple and one of them goes to a nursing home and you have to sell the family house, they changed it now so the surviving spouse can live in the house even though the other person is in a nursing home. But they were taking people's houses away when they went to nursing homes.
Do you know what, Judy, I'm going to stop you because I do want Maria to talk about long-term care. So just to take a look again, so you can see audience members. The left side of the chart shows the savings, right, that we would save with the New York Health Act. And then you can see the right side, what we're adding back in, right? So you can see why it makes sense. We're still saving over $11 billion a year because it is not healthcare that we have in this current system, right? We have these middlemen that exist to deny and delay our care. So removing them, this very extractive middleman from the scenario, we can get better healthcare, actual healthcare, and save money. So moving on, because I know I do want to get to audience questions soon. There's just a quick question for Maria. You know, we talked a little bit tonight about long-term care. I wonder if you can just quickly, for folks who may not know what it is, give a quick overview of what it is. But it's also for those of you that may be unfamiliar with it. Judy mentioned it's very expensive. It's actually $1 billion industry in the United States that results in most families going into bankruptcy. So Maria, can you talk to us about the difficult choices seniors and families have to make at that stage of their life and how you think the New York Health Act would change that scenario?
Yeah, so long-term care basically has to do with, you know, if when somebody needs much more care, let's say in a nursing home. So if, let's say you were gonna live in a nursing home for a whole year, it would cost a person at least $120,000 on the low end. It would cost a person $120,000 to live in a nursing home for a year. However, let's say you needed, but Medicare does not cover long-term care. It only covers very short rehabilitative care, and that is if you qualify under certain rules when you're admitted into the hospital. So if you're not, now if you don't, so this is where the observation status rules begin. If you're admitted into a hospital and you're there for 3 days and they say you are admitted, then you can go to a rehab center and stay there for just a few days and Medicare will cover it. If not, it's on the patient. If the hospital does not admit you and you're coming in either from the community or you're being placed under observation, the patient pays. And Medicare will not cover.
Some people think they're admitted.
Right. So we used to think a long time ago that when you said you're admitted into the hospital, it was like a form of speech, right? Or you're being placed under observation. Oh yeah, they're observing me to see what that's going to happen. Those are insurance terms of how they're going to bill you. It's whether Medicare Part A, which is the in-hospital, is going to cover you, or whether Part B is going to cover you, which is the outpatient. If you're so your insurance might cover you either way, but the way they're going to cover you and how much you're going to pay in co-payments and other things will vary. And usually it will be more expensive if Part B is paying. So by doing that, I always say a patient is always one observation stay or one hospital stay away from bankruptcy. Bankruptcy is the biggest reason why families go into debt, and medical debt is one of the biggest reasons why people go into bankruptcy in this country, and a lot of it has to do with these practices. Under New York Health, long-term care will be covered, so we won't have to worry whether we're being placed under observation or being admitted to the hospital. We don't have to worry about that. I always say the patient's job when you're in a hospital is to recover. But if you're worried about who's paying for my bill, am I going to have to worry about when I get out? That'll put me right back in the hospital, right? You're not going to recover. Your family is not going to recover because many times the children of the person who's in the hospital, are they going to let their parents go without? No. And then what happens is that family caregivers usually pay about 20% of their own incomes for the care of their parents. That could be their bills, it could be their home care, it could be whatever expenses they need. And then the other thing is that those burdens will always inevitably fall on the family. So long-term care is such an expensive proposition that the New York healthcare can ameliorate tremendously.
I think it's really exciting. You know, in New York alone, 740,000 New Yorkers have some type of medical debt, right? And I wonder what the percentage is for folks that are facing long-term care issues. You know, for me, when I think about it, as someone who is kind of in the sandwich generation, and I think of my mother-in-law, and I think of some of my aunts, it's a terrifying proposition to think about how we would afford to give them the care that they deserve. And seniors should be living out their lives in dignity. If we think about the senior citizens in our lives, think about what they've given to our families, to our communities, to our state, and we treat them with such disrespect in this current healthcare system. And it doesn't have to be that way, and under the New York Health Act, it won't be.
And just to add on to something more, to look at it pragmatically as well, for younger generations, right? The caregivers, like I had said, they pay an average of 20% of their income to take care of a family member, right? So let's say you're a woman, you're making less money than a man, right? You're making 80 cents on the dollar. Let's say you've been in and out of, you're being a caregiver, so you may not be in the workforce. You haven't been able to accumulate wealth along those times because you're caring for your family, you're doing what you need to do. You're in the sandwich generation. What ends up happening is when we look down the road, right, and we've expended not only our energy but our resources, when it's time for us to receive that care and to retire and to receive that care, we might be worse off than the people we were caring for. And so just to look, we have to be very, this is a very forward-thinking bill that will not only be less expensive, but it will also preserve our resources. We are living much longer now, right? So we, especially women, need to be able to preserve the money and the resources that we have been able to build during our working years so that when we live longer, we're still able to survive and thrive in the community.
Right. Thank you. So we really do need to get to audience Q&A, so I'm going to have to cut these questions short. There is one question that I do just want to ask, but I'm going to give you and/or Dick, whoever wants to answer it. Literally, I want the top lines, no more than 3 minutes, because we do have to get to Q&A. But a rarely discussed benefit of the New York Health Act is the fact that, and I think particularly interesting for Long Islanders, is the fact that the New York Health Act has the ability to save a significant amount in property taxes. And so I wonder if you could just give us the top lines. I'm going to have to cut you off in 3 minutes.
So, property taxes come from the schools and from the county. And both of those, and the libraries, and some of our special districts, most of them are labor heavy. So on any group where you have a lot of the budget is wages, where healthcare is currently getting paid, what's going to happen is they're going to save a bundle of money on health insurance. So, for example, I did a study with a mayor of a town upstate, 900 people in the town, 900 employees, a budget of about 6 million, and by New York Health, looking against the actual wages of those employees, they would save 18% on their total budget. Done studies with Nassau County, slightly from a distance, not looking at every single wage, which is the right way to do it, and it's been 18% to maybe 25%. That's a lot of savings. I can't guarantee that Nassau County would in fact drop the property taxes, but if they didn't drop the property taxes, you would expect them to do something useful with that money. And the schools, we're talking another 15 to 20%. They're paying for health care, and they're paying for health care of the current employees and the retired employees, and depending on the jurisdiction, paying for the retired employees can be as much or more as what you're paying for the current employees.
Thank you, Judy. So we got that, right? More comprehensive healthcare saves us money and has the propensity to save us some property taxes. Sounds like a good deal to me. So at this point, I do want to open it up to audience Q&A. And before we close this evening, I'm actually going to see if the author of our bill wants to give us any parting wisdom. No pressure, Dick. But why don't we take some questions from the audience?
So if you have a question, please just raise your hand. I will come to you with a microphone so that people watching on live stream can also hear your question.
All right, so the data, the anecdotal evidence, it all points to the fact that this is an effective and important act. How do we make it happen? How do we take the power of the profits of these insurance companies that they can use to buy the favor of lawmakers and fight that? How do we make this happen?
Dick, would you like to take that one?
Well, as of now, and it's been true for some time, a majority of the members of both houses of the legislature are co-sponsors of the bill. Why hasn't it, zoomed to enactment? I think the primary reason is that an awful lot of the labor movement strongly supports the bill. Any labor leader you talk to about this will say, every time we're at the bargaining table, we have to sacrifice wages and benefits to protect the union health plan. Many of those labor leaders say the New York Health Act will mean that healthcare is no longer part of, something we have to bargain for. It's a human right. There are some in the labor movement who I think see themselves almost as health insurance companies and are very identified with their role as providing health benefits to their members, and they don't want to give it up. And so even though the benefits to their members and the savings to their members would be dramatically better, some of the labor movement is opposing the bill. And in a state with Democratic majorities in both houses of the legislature, getting a bill passed that a significant chunk of the labor movement is not on board with can be very difficult. I think if individuals and organizations that support the bill speak up and say to their legislators, for crying out loud, this is enormously important to me, get it done, I think we can get it done.
Thank you. And I just want to add also, the Campaign for New York Health has regional hubs around the state. We do have one in Long Island. If you're an individual and want to get involved, you can see me after the program. We also have a statewide coalition for organizations to get involved in. We certainly could use your help helping us educate lawmakers on every level, on the town, county, and state level about this bill. Next question.
Is there any provision in the New York Health Act regarding the logistics of switching over from the current terrible situation to this, in terms of both the logistics, but also in terms of the job losses, or just some messaging about the people concerned about all the loss of jobs associated with this behemoth of a business?
Those are two important questions. It would take New York probably a couple of years from the day the governor signs the bill, God willing, to when it can start paying claims. Setting up a government program has gotten a whole lot more complicated over the years. When Medicare was enacted in 1965, 11 months after Lyndon Johnson signed the bill, they were paying claims. Today, it would probably take a whole lot longer, even though, we no longer use rotary phones or carbon paper. Government administrative processes have just gotten a whole lot more complicated. So it would take time. to enact all the regulations and make conforming changes in regulations, etc., to get it up and running. But like they say, the best time to plant a tree is 20 years ago. The second best time is today. We got to get this going. The second question. Job loss. We worked with 1199, the Drug and Hospital Workers, the Health and Hospital Workers Union, on transition language for employees who lose their work as a result. And there are about 20,000+ health insurance workers in the state of New York. Almost all of them, their jobs would no longer be necessary. Hospitals and doctors, the army of workers that they hire to fight with that army of insurance company workers would no longer be needed to do that work. What Rand and other studies have found is that by putting all these billions of dollars back in the pockets of consumers and employers, etc., pumping that money back into the economy would generate about 200,000 new jobs in New York. And so under the bill, there is language to use some of the revenue in the New York Health Act Trust Fund for retraining, for relocating, for extended unemployment benefits. But by and large, it will be an enormous benefit to the New York job market.
Next question?
Just to follow up with what you just said, but if they're getting paid more, then they could keep some of those employees. Because you said that Medicare, the private insurance, they're going to get paid what private insurance, which usually pays more. So some of those employees, they might not have to lose.
If they took nurses so when my husband was sick for 2 solid years, and I often would come out, and his nurses would be arguing with insurance companies. So they also had other people who argued with insurance companies, and sometimes the doctors did. What you're asking is, would those people have to be fired? No, they go back to being doctors and nurses full time, and social workers.
Right, and I think, the piece of it is and I think Dick alluded to this earlier, Dick or Maria, I'm sorry, but one of them alluded to earlier is the fact that in any given doctor's office, right, we often see sometimes double the amount of staff as our billers, right? And they're fighting with insurance companies, or they're calling you to get your copay or your co-insurance. That particular skill set would not be needed because everything would be covered. But I think what's so great about this bill is that there really is a just transition. There's extended unemployment insurance benefits for folks that are transitioning. There is retraining. There's a lot of assistance to help usher them into new jobs. And those skill sets, it's largely administrative, right? So it's not such a unique skill set that it wouldn't easily transition into another field.
Does that answer your question?
Next
Hi.
question?
Yes. I just wanted to say a thank you to Dick, especially because
I know, right?
prevailing from 1991 and still going strong. I'm so pleased to see you and to be here with all of you, but particularly I've been to another
Well,
panel.
They say when you find a job that you love, you never have to work a day in your life.
Well, it's so wonderful for me to see you again. I mean, at least I've been to something like this at least 10 years ago, and I think 10 years before that. And I just want to say, well, what's the likelihood of having it happen finally? What's the major, is it the insurance companies are the major obstacle? What can we do about it? How can it happen finally?
Talk to the organizations that you're a member of, get them to pass a resolution supporting the bill, get them and you to let your state assembly member and state senator and the governor know where you stand on the bill. If you want to get more involved, the Campaign for New York Health, the League of Women Voters, Statewide Senior Action Council, they all are actively involved in supporting the bill.
Yeah, and I just want to add too, where historically there has been some hiccups with labor, over the last year we've advanced many of the conversations. We just had a new union come on board and make the New York Health Act one of their priorities in 2025, UAW. So, we are definitely making progress on that front. But I also just want to add, and I think this is really important, right? Because for us in this room who think this bill makes a lot of sense and actually sounds pretty great, it's frustrating, right? Why wouldn't they pass this bill? It's an amazing piece of legislation. Thank you to Gottfried for writing the bill. When we think about social change in this country, it's never been easy. Right? It's never been easy to really get something good. Look how long it took us to get the right to vote. And I like to tell this story. I don't know if Dick knows this, but I like to tell this story because I was in a meeting with Dick and someone said, how do you keep going? How do you keep doing it? Your energy, you're amazing, but how do you keep the momentum up? And he shared that he believes, or he said that, when I think about laws in New York State history that really changed society for the better, I think of, the public education system, I think of abolishing slavery. And then he had a long pause in that typical Dick Gottfried way, and he said, and I think about the New York Health Act, because that's the significant impact that this bill will have on society. So we can't relent, and we've got to keep building, and we've got to keep going. And I do think right now, while we have so many federal changes happening, New York has an opportunity and responsibility to protect us, so I think our window of opportunity is actually bigger right now.
And let me just say, every single one of you who says this is a good bill, think about every organization you belong to. Some people who know me know that I belong to a theater board of a nonprofit theater in New York. I have contacted every nonprofit theater I know and discussed this with them. And amazingly, most of them have never heard of it. Now, mine heard about it in 2018. And they said, what, really? Yes, absolutely on board. Unemployed actors could really use this. The others are also doing that. Talk to your groups. Make sure they at least know about it. If they have questions and they have trouble believing you, or you can't be quite as detailed as Dick and Melanie and Maria, get them involved with the campaign. You can go to the campaign, you can sign up, you can do things. And I would suggest you start getting the organizations you belong to know about it. And if you know anybody upstate, feel free to get them involved too.
We have a question here in the back.
For someone unfamiliar with the legislative process, you said that this is an active bill. Are we talking about the early stages of the introduction of the bill? Is it something that all legislative members are quite aware of, or is there some education and advocacy that still needs to be done? It's very, all these things are unclear to me.
The bill was introduced in 1991, and it has been introduced in every session since. Some folks don't understand. They hear about this bill and they're like, well, where is it? What's going on with it, right? So it is a live bill. We just got new numbers this week for the Senate, actually yesterday for the Senate. We now have the new numbers for the Assembly as well. It is something that every legislator in both chambers has received some education on. And I don't want to embarrass Dick, but when he was in the Assembly, he did these incredible education sessions with his colleagues that I very much miss and wish he was still there to do. But that said, legislators are very busy and they have hundreds of bills coming across their desk. So I think as much advocacy as we can muster is what we should give. It never hurts to bring more education and more advocacy to every single legislature in both chambers.
I want to know, is the Teamsters or the teachers' unions behind this?
Sorry, did you say, are the Teamsters and the teachers' unions?
Are they on board with this?
The Teamsters have not come on board yet. I have had some conversations with them and they were unaware of the bill. So, work in progress. With regard to the teachers' union, and probably Dick could speak more to this than myself, they used to support Then they pulled back support, but we are having, I would say, very productive conversations with both NYHA and UFT at the moment. But I don't know if Dick, you want to share anything there.
I think with the teachers, that's right. I know Senator Gustavo Rivera, who is the Senate sponsor of the bill, the chair of the Senate Health Committee, has been having quite a few conversations recently with the UFT in New York City and New York State United Teachers statewide. He feels there's beginning to be a little progress. One interesting quirk, the woman who is the head of New York State United Teachers, when she got married, Senator Rivera officiated at her wedding. You never know.
So when we get this done, what are we going to do about all the other Americans that are going to want to move to New York? Because that's going to happen. I know if I lived in South Carolina and New York said, I'm going to give you free health insurance, health care, you know, I would be there. So what are we going to do?
We'll need more housing.
Well, you know, people often ask that question. You know, New York has a better Medicaid program than any other state. People say, well, gee, wouldn't people flock from all over the country to come here? In 1990, we copied Minnesota and adopted what is called Child Health Plus, a wonderful program. And people thought, gee, you know, maybe people with sick children will move here from all over the country. It just doesn't happen. Why, I'm not sure, but it doesn't happen. I think what will happen is that once one state enacts a single payer system at the state level, other states will follow suit. By the way, the Child Health Plus program, Minnesota did it. New York shamelessly plagiarized what Minnesota did. Within about a half a dozen years, the federal government passed a law that said to any state, if you do what New York and Minnesota have done on child health, we will pay 2/3 of the cost. Within a couple of years, every state in the union now has a child health insurance plan like New York. That's how single payer coverage came to Canada. Saskatchewan did it, and then another province did it. And before you know it, their national government passed a national law that said any province that does what Saskatchewan did will pay the bulk of the cost, and now it's nationwide in Canada. And so I think that's what would happen. Once a couple of states take action, it'll go nationwide. That's how most good legislation in this country happens. You know, our labor laws, our wage and hour laws, child labor laws, worker safety laws, all these things began at the state level, by the way, usually in New York, and then went nationwide. Not to compare the two, but New York was the first state to abolish slavery in 1827. Took the rest of the country a long time and a war to catch up.
Wyoming did women's votes first, though.
Excuse me?
Wyoming did women's suffrage first.
Yes, they did. That was a struggle that took a long
60
time,
years.
starting in the 1840s.
But a lot of the best legislation takes a long time, and I would like to second that. California keeps trying. Oregon and Washington are now actually have a bill, Oregon has a bill that it's working on, and Massachusetts has a single payer bill that it is really close on. So yeah, this is not, New York has a huge economy relative to Oregon, not to California, but we have a big enough economy that we can make it work.
Yeah, we're not standing alone, but we can definitely lead.
Hi, I really didn't think I'd get up and speak, but I am a retired New York City teacher as a member of the UFT. And I don't know if you heard about the Medicare Advantage debacle that happened over the pandemic. So in 2021, Michael Mulgrew and Eric Adams, apparently U of T and NYHA are two different health plans, two different things, even though I'm supposed to be a member of both. Anyway, Michael Mulgrew, Eric Adams decided they were going to push all the retirees into Medicare Advantage. And at first, all my friends thought it was a great idea, except for one. One friend of mine said, just like you don't buy a new car when it first comes off the lot, I am not going to change insurance until I see what's going to happen. As it turns out, Michael wasn't fighting for us, he was fighting against us. Another organization had to step up. Do you realize it was a New York City retirees? They were not teachers. They were all the rest of the retirees in the city. I'm terrified. And I'm not sure, I mean, I thought about getting up and I wasn't sure what to share. I am not getting the impression that my union is going to help me. And I'm terrified. I'm sorry.
So I'm not a union member, I only read the news, and I kind of remember some set of union leaders getting deposed last August because the workers voted.
Yes.
You could speak to that better than I could, because I just read the papers.
Okay.
Sharon, I just want to say, firstly, hi, thanks for coming tonight.
Hi.
That was almost an unbelievable thing that was going on with the teachers, right? And I think we often think of these big entities as all-powerful, and to see the retirees come together and fight back and seemingly are winning, I think that just speaks to the power of advocacy and really how important our voices are collectively. And it kind of really meshes well into what we're saying, right? I always say, if you think you can't have nice things, you're absolutely right. But if you think you can have nice things, you're absolutely right. Right? So we have to believe in the power of us, in the power of collective action, and never give up. Because I think that story, the way the teachers and the rest of the retirees have come together and really took on the real power, are an incredible example to all of us.
It was, go ahead.
Oh, no, I just have a question about doctors and nurses who have somewhat become autonomous. You know, they're stuck in the system too, and they have short times to see their patients and all that. Have they supported the bill? Are they on board? Like, I think it would give a lot of credence to this if there was a lot of them supporting it.
Yeah, the State Medical Society is neutral. As you may know, the organized medicine is not one of our more progressive forces in America. They opposed the enactment of Medicare tooth and nail. But the State Medical Society does not oppose the bill. They have moved to a position of neutrality. We have gotten to some of the bill language from them. We said to them, if you've got good ideas for improving the bill, let us know. We're not, I'm not saying we'll only put your language in the bill if you endorse it. And so a lot of the language in the bill about how payment rates will get calculated were written for us by the Medical Society. A couple of major organizations, the American Academy of Pediatrics strongly supports the bill, has for a long, long time, and the American Academy of Family Physicians also supports the bill. They are, by nature among the more progressive voices in the medical profession, but they strongly support the bill.
There are 20 medical societies that support it. I'm on the Physicians for a National Health Program board of New York, for the New York City chapter, and they aggressively try to get doctors to support it. There are two issues. One issue is many doctors now are employees of health insurance, so they are their First Amendment rights are sometimes abridged because they can't publicly endorse things. And the other piece is many doctors, something like 80%, have a sense of moral injury about the fact that 20 minutes isn't enough, no eye contact is enough, that patients, the kind of healthcare patients get is determined by the kind of insurance they get, because if they can't afford what they actually need, they will get something lesser, and that is not why people went to medical school. I mean, honest to goodness, most doctors did not go to medical school to get rich. There's easier ways. They went to medical school because they wanted to make people well, and now the health system is such that they feel compromised. That's called moral injury. And we are losing doctors because they leave the profession, nurses do, because they are so conflicted and miserable. So yes, organizations are beginning to support.
So one of the concerns I hear about the New York Health Act is that people are confused as to what exactly would be covered with those things. So if someone has an insurance plan, they're like, well, I can get Invisalign covered here. Am I going to lose that? Or my contact lenses are covered. Am I going to lose that under the New York Health Act? Can you explain just how things would be covered and what that standard is?
Yeah, I've, working on this bill for 35 years, I don't think anyone has ever come up to me and said, my health coverage covers X, does the New York Health Act cover it? And the answer wasn't yes. I haven't heard anyone show me that they have health coverage that covers something that isn't covered by the New York Health Act. Now, the way the New York Health Act spells it out, since it's 35 pages, not 3,500 pages, it doesn't list broken bones and cataracts and gallbladders. It says any health benefit that is covered by any of the following would be covered for all 20 million New Yorkers. So anything that is covered by traditional Medicare, by New York Medicaid, which covers more than national Medicaid does, Child Health Plus, any of the mandates in our state insurance law, and significantly, any health benefit that is provided by any state or local public employer anywhere in New York State will be covered for all 20 million New Yorkers. And so, long-term care, gallbladder surgery, you name it, is covered by the New York Health Act. And again, I've never had anyone come up to me and say, my health plan covers X, does the New York Health Act cover it? And the answer wasn't yes, and in fact even better than the way your health plan covers it. Because there's no deductible, no co-pays, no restricted provider network, et cetera, et cetera.
And because remember, it includes medical care, dental, vision, hearing, long-term care. It will be the most comprehensive. Yeah, that will include behavioral and medical, but it will be the most comprehensive plan in the entire country. Thank you, Dick, for that. Any other questions?
By the way, for many years as a public employee and now as a retired public employee, I have on paper dental insurance, except the provider network is so restricted and the payment levels are so inadequate that there's practically no dentist in the state of New York that takes it. A few years ago I had a tooth pulled and it cost $1,200. My employee health plan paid a grand sum of $82. And that would never happen again under the New York Health Act because dental care is covered, no restricted provider network, there is language in the bill that spells out to guarantee that provider payment levels will be reasonable and adequate. And so my dental coverage under the New York Health Act would be a whole lot better than my public employee dental coverage has ever been.
There's a question?
Where does our governor stand on this bill? And if positively, how do we push it, move it along? If not, how do we push it back in? And what about where some of our opponents in the upcoming gubernatorial race stand, if you know?
Do you want me to speak it?
Could you repeat? I couldn't.
Sure. The question is, where does the governor stand on the bill? And if she doesn't, if she doesn't support it, how can we move her to support it? And where do her opponents in the upcoming gubernatorial primaries stand, or I guess opponents across the board?
I don't think the governor has a position on the bill. We've been trying to get the governor to have the health department at least look at the bill and give us their technical comments on it, not necessarily on the merits, but technically are there things we ought to fix. We haven't gotten them to do that. And again, I think the problem that the governor has with it is very similar to the problem that many of my former colleagues in the legislature have, which is that some voices in the labor movement are not at all on board. And I think that makes it a difficult step for a Democratic governor.
Does that answer your question?
Yeah.
Okay. Are there any other questions? Someone in the back?
I'll just speak up. So, from what I've heard multiple times, one of the key constituencies that's against it right now is the labor movement, some of the labor movement. So, what kind of advocacy and individuals that do with these organizations to try to begin to move the process along? Because I keep hearing that a lot of times it's labor has their reasons for opposing the bill, and a lot of it's getting stuck in that area. So that's my impression.
Melanie, can you repeat the question?
Sure. So the question is, if, and I'm going to paraphrase, if the major holdup for passing this bill exists in the fact that certain labor leaders do not support, what can individuals do from an advocacy stance to influence and get labor on board?
I think if you're a member of a union or either an active employee or a retiree, speak to your union leadership, make sure that they know where you stand on the bill, and similarly, make sure your state legislators know where you stand on the bill.
Yeah, and I would also just add, a lot of folks don't know about this bill, right? We're not funded by the folks with the deepest pockets, right? We are we're funded by individuals and folks that really believe in centering people, which sadly these days is a rare minority. So I think the more you can, as an individual, can bring awareness to this bill and educate, whether it's social media, it's in your networks, etc., that all contributes. If every supporter of the New York Health Act were doing those things, that would have an impact. Because you may not have, I don't know if you're a union member, but if you're not, it's going to be very hard for you to make an impact in labor. But you may have a friend that is in a labor union who might see some information you're putting out there, who may then in turn ask you, and it starts the ball rolling that way.
And one thing I will say, I think all of us do this. If you belong to different groups that you would like to get interest, invite us. We make presentations. We go anywhere we're invited. So, and I could say I work, tomorrow I leave for Albany and I'm going to be gone for 10 days talking about these kinds of things and all over the state. And so I think every one of us would come out gladly to talk to any group, large or small, and it could be a Zoom, it could even be a Zoom thing. If you have monthly meetings, invite us. That's what we do. So we're happy to do that.
And also, this recording will be on the Landmark on Main Street YouTube channel. So anyone that you know that wanted to be here tonight but couldn't, you can direct them there. They can review the entire recording, and that's a great resource. And I'll send everyone here also an email with that link as well.
And I would like to thank Angela Jagger, who I met in 2018. I was brand new to the league. I joined the league because it supported the New York Health Act. And I was trying to figure out how to do it. And at one of the first league events, somebody said, oh, if you're interested in that, you ought to go talk to Angela. And I wanted her to talk to Angela, and she said, yeah, we should do this at the Landmark. And I said, really? So, thank you, because we're back because of Angela again. So, her long-term support is really heartwarming and great, and gets the word out to people.
Thank you, Judy, for that.
Before we close, I just want to give Dick Gottfried the opportunity to share any imparting wisdom. As I said, he's the author of the bill. He is the father of the movement in New York. And Dick, I want to personally thank you. I'm so grateful that you traveled out here tonight to be with us. I just want to give you that opportunity. Of course, Maria, if you want to add anything.
Well, thank you, and thank you all for coming. Thank you all for your questions. And I guess what I would just reiterate is, if you support the bill, speak up, write to your legislators, contact organizations that you support, that you're part of. We're not necessarily asking organizations to devote every waking minute to working on the bill. If they can find out more about it and simply pass a resolution supporting the bill, we can help spread that word. But we need the groups that you're a part of to learn about the bill and to say, yeah, count us in. Thanks.
Great. Well, thank you so much for your time this evening. We look forward to seeing you in the fight to bring about universal health care in the state of New York. Good night, everyone.